Ronnie George was trained by one of my close friends, Ravi Thomas, if I am correct.
You are very much correct, sir. You have met us at that time also. So, I'll speak to you about optic disc evaluation in glaucoma. And basically, the reason why it's important to look at the optic disc is because you must have heard this 10 times in this conference already that optic disc changes can precede visual field changes. So the standard is to use a slit lamp microscopy because you need to use a binocular method of assessing the optic disc, which is a three-dimensional structure. So use a 60, 78 or 90 diopter contact lens. If you have a dilated pupil, the 60 diopter is the best. If you have a small pupil, the 90 diopter is the best. The 78 is a good compromise between the two. And don't forget that the image that you see will be inverted when you take a look at it. So one of the disadvantages of the 90D is a limited magnification that you get with it. It's very simple to look at the disc. You just need to observe the 5 R's. The first is to observe the scleral ring to look at the limits or the size of the optic disc. The next is to identify the size and the shape of the rim. The third is to examine the retinal nerve fiber layer. And the fourth is to look at the region of peripapillary atrophy. And the fifth and the last one is to look for retinal and optic disc hemorrhages. So these are the 5 R's, and if you follow this, you can usually assess most discs accurately. So how do you identify the scleral rim? And what you do over here is you have to look at where the vessels bend. Look at the region of the vessel bending, and that is the edge of the rim. That's the edge of the cup. The scleral rim is this whitish, slightly elevated line that you will see all around. It's sometimes a little difficult to identify in myopes, but most of the times you can identify it fairly simply. Then what do? You can assess the optic disc. So, if you really are mathematically inclined, you can use a formula to look at the disc area. But most of us just would look at the vertical disc diameter, and that will give you an idea of the disc size. Don't forget that each of the lenses that is available to you has different magnification factors. And these are the magnification factors for the different uh, lenses that you use. So if you're measuring on the slit lamp with the graticule and you get a measurement of 1.2, if you're using a VOC 66D, that's exactly what the vertical height is. If you're using a VOC 90D, you need to multiply that into 1.33, that's all. In general, we classify discs like this. A small disc is less than 1.5 millimeters, a medium disc is 1.5 to 2.5 millimeters in area, and a large disc is greater than 2.5 millimeters. And you can see that all three of these are normal discs, but see how the cup has changed in these three discs. So why does disc size matter? And the reason that disc size matters is that the number of retinal ganglion cells in an eye remains relatively constant. It's between 800,000 and 1.2 million. The optic disc size varies much, much more than this. And when we looked at our own data from the Chennai glaucoma study, this is the range of optic disc sizes by planimetry. You can see that most of the discs are in that middle range, 2.5 to 3 to 3.5. The mean disc areas range from 1.84 to 4.23. That is, the disc area more than doubles. And the mean vertical cup to disc ratio ranges from 0.2 to 0.54 in normal people. So your cup to disc ratio is very much dependent on your disc size, and that's why it's important that you should look at disc areas. These are two normal discs, and both of them look very different in terms of the cup. And this is because in a normal population, the disc size can vary by as much as 1:8 times. There is almost no other organ in the human body where you will see an 800% difference in size. You don't see people who are 1 meter tall and 8 meters tall. You don't see people with, axil lengths like that or any other feature like that. So that's one of the reasons why it becomes difficult to assess glaucoma sometimes. So we finished identifying the size of the rim. Now you look at the rim, and the rim you need to look at two things. You need to look at the contour and you need to look at the color. So the neuroretinal rim in glaucomatous damage, you look at contour and you look at color. And how do you assess the borders of the disc and the cups? You assess the borders of the disc there. Now you assess the borders of the cup by looking at each area where the vessel is bending. It's important that you look for that. Don't look at the white area in between and think that is a cup, because if you look at this disc, where do you think the cup is? Most of us would take a quick look, and especially if you're not paying attention, you would just put it there. But the actual cup is there because that's where the vessel is bending. And when you do that, you realize that there is some inferior thinning, and you can see that the edge of the vessel is right there. So that's why it's important that you look at the vessel and not the color. The next thing that you look at is how is this rim distributed? What's the pattern? And all of you are familiar with this. Is the IST rule. This is a normal, about 3/4 of this follow this pattern, that the inferior rim is thicker than the superior rim, which is thicker than the nasal, which is thicker than the temporal. And in general, no part of the optic disc will be thinner than the temporal rim. So you will not get even a local area which is thinner than the temporal rim. So what all can you see? So like this, you're seeing a disc. Here the inferior rim is a little thinner, but that thinning does not extend till the edge of the rim. Therefore, this is an incomplete notch. Conversely, in this eye, you have complete loss of the rim in the superior area, and that's a complete notch, which you will usually see with the defect coming close to fixation. Here you're seeing concentric thinning of the neuroretinal rim, and that's going all over there. Look at where the vessels are bending. And this you can typically get with it very high pressure glaucomas acutely or latent disease. The other thing that you need to look for is cup to disc ratio asymmetry. So if you look here, you can see that in this eye, your cup is fairly large and this eye is fairly small. This sort of asymmetry is rare. Any cup to disc ratio asymmetry of more than 0.2 with similar disc sizes should be looked at much more carefully. How do you assess disc symmetry? Quite easy actually. This is a pair of asymmetric discs. In fact, this is, any of these are glaucomatous? What do you think? It's a colleague's photo actually. He's also a glaucoma specialist. So it's his picture, and that's what the optic discs look like. You put them together, and when you look at the sides, you can see that the yellow is definitely larger than the green, and that's the reason that the cup is also looking larger. And there's nothing wrong with it. A pale rim increases the likelihood of a non-glaucomatous optic neuropathy, and there's a separate talk on that, so I will not go into that. So the next structure you look at is the retinal nerve fiber layer, and this is where all of us become a little lazy because we don't feel like changing the little dial on top and putting on the red free. If you put on the red free, you can see it much better. You can see it even better if you take a red free picture. So what all do you need to do over here? You need to look at the brightness, the striations, whether you can see the peripapillary blood vessels, and whether there's diffuse or localized nerve fiber layer loss. So typically this is how your nerve fiber layer is distributed. You have a bright zone which is on top, then you have a dark zone which is next to the macula, and you have a bright zone. So it's bright, dark, bright. This is what you should expect to see in every eye. When you have a nerve fiber layer defect like over here, you're seeing a localized dark zone in a bright area. And this is easy to visualize. There's also a disc hemorrhage there. So this is a patient with the superior notch that I showed you before, and you can see that wide dense RNFL defect. You can see how the blood vessels there are much better visible as opposed to any other area. And this is one of Yost-Jonas' rule, who says that every disc has an RNFL defect unless you prove it otherwise. Basically, it's telling you unless you have ruled it out, you cannot say there's no RNFL defect. So this is somebody with a more subtle defect. You can see that there is some difference in contrast between here and here, but this is again something that you will not see unless you look with a red free picture. Now you look for the areas of peripapillary atrophy. And why is the peripapillary atrophy important? It's important because of increased visibility of the choroidal vessels and sclera because of the atrophy of choriocapillaris, which can also be a sign of glaucoma. So the alpha zone is not that significant. It's a regular hypopigmentation of the RP. A progressive increase in the peripapillary atrophy can be a sign of increasing damage, like in this disc over here. So what you're seeing over here are the green arrows are the alpha zone, and the yellow arrows are the beta zone. So this is better differentiated. You can see that green arrows there, and you can see a localized inferior beta zone. If you look at the vessels carefully, you will see that there is thinning in this area too. So this is somebody who needs to be evaluated in detail for glaucoma. The next thing that you look for is the retinal and optic disc hemorrhages. And here when you look at what you need to realize is that they're not permanently there. They come and they go. They often disappear in 1 to 3 months. And this can indicate future glaucomatous progression, at least in Indian eyes. So this is an optic disc hemorrhage that you're typically seeing. It usually crosses the border like that. It's usually at the superior or inferior poles. At the nasal and temporal, it's unlikely to be glaucomatous. So here you have something which is just on the supratemporal pole. It's a resolving optic disc hemorrhage. So when you're looking at the 5 R's, scleral rim, RNFL, peripapillary atrophy, disc hemorrhage, the size, remember to measure the vertical diameter or describe it as small, medium, or large. Once you have done a few measurements, you will get used to doing it as small, medium, or large. The rim, is the Isn't pattern followed? Is there localized thinning? Is there pallor? These are the 3 questions that you need to answer. RNFL, very simple, is there a defect or not? Peripapillary atrophy, is there peripapillary atrophy zone alpha or zone beta? And finally, an optic disc is just again a yes no question. So if you cover these points, you can actually be fairly sure of having assessed your disc reasonably well. So how do you document this? You can write it, which is not a very efficient way of doing it. You can draw it, which is much better, and drawing it actually makes you focus on each part of the disc. Photographing is of course the best way, or you can use something like the DDLS scale, with which you can sort of classify the disc into each of these groups. This is available online without any problems. I never spoke to you about the vertical cup to disc ratio. No, that's what all of you are writing. All of us are writing. Why didn't we do it? Because it is most dependent on the optic disc size. So the vertical cup to disc ratio has really no value. And if I look at the same disc twice, I'm likely to have a difference of at least 0.1 plus or minus from my last reading. If I and you look at it twice, we might have a difference of 0.2. So it has very, very little value. The only value it has is if you measure the disc size and then you put on a vertical cup to disc ratio and you mention what's happening with the rim, then perhaps. So what do you think about this disc? Glaucoma, not glaucoma? Show of hands. All those who think it's glaucoma? Okay, you are all right. Why? Because there's inferior thinning, and if there's an inferior nerve fiber layer defect, better visible on this. What about this? Is the disc small or is it medium or large? How many for medium? Okay. Okay. On disc photographs, it's difficult to assess because it depends on what magnification you have used to take the photograph. But yeah, I agree with you, it's medium. So glaucoma, not glaucoma. Very good. All of you don't need the class. So it's a medium-sized disc with a large cup. The RNFL looks perfectly healthy. There's no localized thinning. What about this? Glaucoma. Very good. So this is a large disc, concentric thinning, both inferior and superior. But there's no nerve fiber loss. Why is that? Because when you have concentric thinning, you have uniform loss all around. So you're not seeing a localized defect. So this is something that you need to watch out. So just because you don't see an RNFL defect doesn't necessarily mean it's not there. So careful systematic assessment of all the discs by applying the 5 R's is really helpful in detecting early glaucomatous damage, and I hope the class helps. Thank you.
Thank you, Dr. Ronnie. That was a wonderful in-depth overview on optic disc evaluation. Are there any questions?